Okay, so this is the second video of the ENLS videos that I'm going to be doing. In this one I'm going to be talking about the acute ischemic stroke. And most of the information I'm going to give you here is based on this article of the Neurocritical Care Society. So let's begin. Just a brief introduction with epidemiology. Remember that there are two types of stroke, ischemic stroke and hemorrhagic stroke. But ischemic stroke comprises about 83 to 87% of cases of stroke, and the remaining cases are due to hemorrhagic stroke. This can vary depending on which population is being studied, but that's mainly how most of the populations have their numbers. So in this video I'm gonna focus mainly on ischemic stroke. And so how are we gonna identify a patient with an ischemic stroke? Well, the most common presenting complaint is gonna be a sudden focal deficit, and look at the bold words that I put here: sudden and focal. Okay, these are characteristics of ischemic strokes. Okay, and what is a focal deficit? Well, it can manifest in any of these ways, such as facial weakness, limb weakness, ataxia, aphaxia, dysarthria, visual field loss, gait preferences, or any other sensory disturbance. And there are some pre-hospital scales that focus on these focal deficits, which can help us identify a patient with a stroke in the extra-hospitalizary setting. Okay. What about stroke mimics? Well, stroke mimics refers to some conditions that are not strokes but can present as a stroke and can lead to a patient that has any other condition to receive treatment that doesn't need. Okay, what are the most common stroke mimics that we know? Well, as you see in the list, we have seizures, low glucose mainly, any other toxic or metabolic disturbances, delirium, space-occupying lesions, migraines, and all the others that you see here. Well, how can any one of these be confused with a stroke? Well, seizures mainly is in the after the seizure, when the patient is experiencing a thought paralysis. Remember that this thought paralysis, the patient is sometimes unable to move, a limb, probably the hand and the foot. So this could look under a stroke mimic. And the main way to differentiate this from a natural stroke is that patients have the history of having a seizure before the onset of this limb weakness. Okay, but it is a real challenge when the seizure was not evidenced by the healthcare provider, so he really doesn't know if this is a seizure or a stroke. Most of the time, this is going to be a stroke mimic that is present in young patients, whereas stroke is present in older patients. Okay. What about toxic metabolic disturbances? Okay, many toxic metabolic disturbances such as ion disorders can present with limb weakness, but keep in mind that the most important here is glucose. Okay, and actually I highlight glucose because it is the only lab value that we should wait before we thrombolize a patient. Okay, because low glucose can and is actually one of the most common stroke mimickers. Okay, so at least you should get a capillary glucose before you give your treatment to a stroke patient. Delirium, well, delirium, it happens, can be confused, but there are certain things that can help us differentiate this from a stroke. Okay, delirium, remember that it is usually fluctuating. Okay, and basically what is affected is the state of consciousness. So the patient has a fluctuating state of consciousness, whether in a natural stroke, remember that it was a focal deficit, and in a natural stroke the patient won't have fluctuating symptoms. Okay, once it happens, the patient has the symptoms established. And space occupying lesions, of course, This can give you a focal deficit, but remember that if it is a tumor, the deficit will be established over a period, over a longer period of time. Okay, the tumor doesn't grow that fast, and so remember what was one of the characteristics of the most common presenting signs of stroke is that it is sudden. So this doesn't agree with that definition. That's how can we differentiate this. Also, space-occupying lesion can be subdural or epidural hematoma, but with these cases we usually have a history of patients with trauma or taking oral anticoagulants. Okay, migraines. Okay, this is a tough one. It is not the common presentation that a patient has paralysis or weakness after migraine, but some patients present like that, and so we have to be able to distinguish this. When patients with migraines typically are younger, they have a very low NIH. As if we calculate it, they will have low ones. Usually, they have a focal deficit, such as an actual stroke, but is usually preceded by headache. So that's some of the keys that we can help to differentiate these two things. Okay, and well, the list is longer than this, but you can see here some of their stroke mimickers. And but this one I'm not going into detail because these one are easier to differentiate. And as I told you, here are some of the exclusion criteria for thrombolysis. I'm not going to read all of them, just go over the ones that I consider more important. Remember, all of these are important, but I mean, this you can have it either on your cell phone or have a list in your emergency department so you don't miss any patient. And so, what I highlight seizures at onset, well, remember I told you that this is one of the most common stroke mimics. It is not an absolute contraindication. If a patient have a seizure at onset, well, it can be a stroke, but just keep in mind that it can also be a mimic. And also, it is important that probably a patient that actually did have a stroke and had a seizure at onset has an increased risk of bleeding. So that's also why you should be careful with these patients. And the other one that I highlight here is blood glucose. Patients with glucose below 50 milligrams per deciliter, we shouldn't thrombolyze these patients until we give IV glucose. And remember that some of these patients are actually mimics. So once we give IV glucose and we reach normal values in blood, patients are gonna the deficit is gonna be absent after that. Okay. What about bleeding diathesis? I just want to go into this a little bit because remember that in a patient that is that hasn't any comorbidity and has no family or personal history of a bleeding diathesis, we don't need to have these laboratory values in order to can be able to thrombolyze them. Okay, but if we have a patient that has a recurrent nose bleeding, a woman with metrorrhagia, or all of this, well, we need to get this before we thrombolyze a patient, okay? Or obviously, if the patient is taking oral anticoagulant, sorry, we should also get a platelet count and coagulation time, okay? Please review the whole list, but remember that you can keep this at your ED. And what about thrombolyzing stroke mimics? Well, I put you here this article. This is meta-analysis, as you can see, and in this article about 516 patients were included, 560 patients were thrombolyzed, and of these 75 were mimics, of which only one had a major bleeding, which actually this patient died, but was one out of the whole group. So the authors concluded that it is safe to thrombolyze stroke mimics, and so I put this quote here that says, "It is better to give intravenous thrombolysis to a patient with a stroke mimic than to fail to do so in a patient with a stroke." Okay, keep that in mind. Of course, you will try to rule out some mimics, but if you really believe that your patient is having a stroke, you should not withhold thrombolysis. Sorry. Okay, sorry about that. My computer was running out of power. Um, well, let's continue. Okay, so how are we gonna approach to a patient with a probable stroke? Well, first we have to have the suspicion. Remember the sodium focal deficit. Then we will do a pre-hospital evaluation, and are many scales that have been developed to do this pre-hospital evaluation. There's the FAST scale. There's the Cincinnati pre-hospital scale, and there are many others. But the most commonly used one is the Cincinnati scale, which takes into account three factors. The first one is this facial weakness. How can we assess the facial weakness? Well, we ask the patient to smile or to show us their teeth, and we are gonna see this asymmetry of the face, where one side is smiling but the other one fails to do so. The other one thing that we want to assess is limb weakness. We can assess this by asking the patient to close his eyes or her eyes, to keep his arms straight up for about 5 seconds, and we see if both arms remain at the same level. It is important to tell the patient that have their eyes closed, because if they have them open, they can see that one of their limbs is standing lower, and so they can do a compensatory effort, and we can fail to identify this arm weakness. Okay, so we will assess it this way. And the other thing that we assess is the abnormal speech, where we tell a patient a quote, a phrase, and they have to repeat it, and we see if they did it right. Remember that you don't have to have these three factors. Having one is enough to take the patient to the hospital and to suspect a stroke. Okay. And what about once the patient is transferred to the emergency department? Well, we have to do the emergency department evaluation, in which, of course, we begin with vitals. We want to do your ABC. Remember your ABC always. Then we get an intravenous access. Draw some blood samples also for the laboratory values that we are going to order. Remember, the most important one is your glucose. Then we calculate an NIHSS, which is a scale to evaluate the severity of the stroke. And it is important also, once we assess the vitals, to put special attention at blood pressure, okay? Because high blood pressure is a risk factor for bleeding in patients that are going to be thrombolyzed. Okay. After doing this, we take the patient for brain imaging. Remember that the modality of choice is going to be a computerized CT. Even though you are not most of the time not going to be see signs of a stroke, if you catch the patient early, what you want to do, or why you get this CT, is to rule out some differentials, such as hemorrhage or any space occupying lesion. If you rule out those differentials, you can assume that the deficit is caused by this ischemic stroke. Okay. Remember, ischemic stroke is usually seen in a CT after probably 3 to 6 hours, not before that. Okay. There are also some early signs in CT that I'm gonna go briefly to tell you, but you will see. And it is very important to establish the time of onset. Okay, in any patient with this focal deficit, it is very important to establish the time of onset, either by asking the patient when the inability to speech, or when this limb or facial weakness began. Okay, or to ask any of the family members when was the last time that the patient was seen normal. Okay, it is very important. Why? Because this has important repercussions in treatment, as we will see further. And so, what about the NIH? Okay, I'm not going to tell you how you how you evaluate the NIH stroke scale, because you can just print a form and have it in your emergency department, and there is also some applications that you can download to your phone. So I'm just gonna tell you how we classify the severity of the stroke based on the NIH score. And so patients that have scores below 5, this is considered minor stroke, and this is important. I was gonna throw in here some articles, but you should go and look for the ones that you can find, because there are some people that say that minor stroke shouldn't be thrombolized. Okay, some call these too good to be treated patients, but there are some groups that said patients can get worse if you don't thrombolize them. So you can read some articles about this and make your own criteria. Any score from 5 to 15 is a moderate stroke, and any score that goes from 21 to 42, this is a severe stroke. And you should also keep in mind that the higher the NIH, the greater the risk of having intracranial hemorrhage. Okay, so even though this is not a contraindication for IV thrombolysis, you should keep this in mind and be careful with those patients. Okay, actually, patients that have scores over 21 have 17% risk of having an intracranial bleeding. Okay, and as I told you, there are some early signs of ischemic stroke. What are some of those? First and most known one, I believe, is the hyperdense middle cerebral artery, which is shown here. As you see, the right middle cerebral artery is hyperdense here. This is a non-contrast CT. It is the one that you should get in these cases. Okay, and you see here the right middle cerebral artery hyperdense. What is this hyperdensity attributed to? Well, because here is the clot. Okay, here is the clot, and usually blood that is flowing has a lower Hounsfield units that than the blood that is not moving. So when there is a clot, you can see this sign, and you know that probably the deficit in this patient is going to be in the left side of the body, since the affected region is the right side of the brain. Okay, but remember that these clots can happen at any place, at any blood vessel in the brain. So we can see also this sign at other places, such as is shown here, where the hyperdensity is at the top of the basilar artery right here. Well, that's because the clot is there, and this would be certainly a posterior circulation stroke. There's also other signs, such as the loss of gray white matter differentiation. Usually you can differentiate very well between gray matter and white matter, such as you see in this side, but sometimes the differentiation of gray and white matter becomes difficult, such as you see here in this side. We usually look for this sign at the insular ribbon, which is one of the places that is very distal in circulation to receive blood. So this is why this is one of the first places to have this difference, okay, to have this change on imaging. Also the lenticular nucleus, because this only receives blood supply from the lenticular straight arteries. So if you have an obstruction there, you usually don't have collaterals, and you can also see this loss of gray-white matter differentiation early at these two levels. Okay, and there's also sometimes loss of cerebral fissures, such as you see here. Look at this side, you have your fissures very well defined, and in this side fissures are lost. This is mainly due to edema most of the time. Okay. And what is the importance of determining time of onset? As I was telling you, it is very important, because this is what it is going to tell you how to treat your patient. Okay, if your patient has less than 4.5 hours of time of onset, this patient can receive IV thrombolysis. And but if your patient is between the period of 4.5 hours to 24 hours, patients are candidates to endovascular treatment, but not to intravenous thrombolysis. Okay, I want you to look at these two articles that I cite here from the New England, where this window of time, where they'll tell you the specific criteria, okay, the specific criteria to which patients can apply for an endovascular treatment up to 24 hours, okay. Uh, the article that I cite of the Neurocritical Care Society was from 2017, so it doesn't tell you that patients can be treated with endovascular treatment up to 24 hours. I guess it says up to 6 hours, but remember that new articles say that it can be done up to 24 hours, so keep that in mind. Also, in a patient that is in the first 4.5 hours, remember that these patients, regardless of where they were given IV thrombolysis or not, if they have a large vessel occlusion, they are also candidates for endovascular treatment, okay? What I mean by large vessel occlusion, well, any occlusion that is from the internal carotid or the M1 segment of the middle cerebral arteries. These patients have better outcomes if they are treated with endovascular procedure, okay? And what about in a case of a wake-up stroke? Well, this is a changing concept, but I want to tell you what most of the doctors consider is that in case of a wake-up stroke, the time of onset is considered to be when the patient went to bed, okay? That's when we establish time of onset. But you should also go and look another article that was evaluating patients with wake-up stroke. This is the EXTEND trial, and they were able to thrombolyze patients up to 9 hours. Okay, so with some imaging techniques that they used. Okay, so keep that in mind also, and please go check that article. Well, what are other important aspects of management? Well, remember that once the patient gets to the emergency department with a suspiciousness of having a stroke, one of the vitals that you're going to be very careful to measure is the blood pressure. Remember that blood pressures that are above 220 over 120 should always be lowered, okay? And patients should have a blood pressure lower than 185 over 110 in order to be candidates for IV thrombolysis. Any patient that fails to achieve this blood pressure with meds is not going to be a candidate for IV thrombolysis, because having a high blood pressure is a risk factor for intracranial bleeding, okay? Okay, and remember that we don't want to lower the blood pressure to normal values. We don't do that. Remember, the patient has a vascular obstruction, we need to have some kind of high blood pressure in order to get better perfusion of the brain. So we just lower it below 185 to over 110, but not to 140 or over 80. Okay, once we have blood pressure below 185 over 120, the patient is good to receive thrombolysis. Okay, and remember that once the patient receives thrombolysis, we want to keep the patient with blood pressure values below 180 over 105. And this is for the next 24 hours to reduce the risk of intracranial bleeding. Okay, and here is the list of the intravenous antihypertensive agents that are used to lower the blood pressure in the acute setting. Remember, we don't want to lower the blood pressure to normal values, just below 185 over 110. So the most common used agent is going to be labetalol, but all of these can be used. And here is the doses and when to administer. Once we administer the thrombolysis treatment, we should keep the patient recording the patient vitals. Okay, we want to monitor the blood pressure after alteplase, which is the drug that we use for thrombolysis, is the most commonly used one. We give 0.9 milligrams per kilogram up to a 90 milligram total dose. and we give 10% of the dose as a bolus, and the remaining 90% we give over a period of 1 hour. During the infusion, we have to assess the mental status of the patient continuously, okay, and to do a neurological evaluation. And if we see that the patient has any neurologic deficit, any new neurologic deficit, we should stop the infusion and take the patient to get some imaging, or repeat the CT and see if there is new imaging on this CT that tells you there is some intracranial bleeding. I will make a video on intracranial bleeding and some signs that can help you identify a patient with an intracranial bleeding and an expanding hematoma. But remember, this is about ischemic stroke, so I will continue telling you how you are gonna monitor the blood pressure of a patient after giving a BI alteplase. Okay, so for the first 2 hours after alteplase, you have to be checking blood pressure for every 15 minutes. Then from those 2 hours to 8 hours, you have to be checking it every 3 minutes, and the remaining 16 hours you have to check it every hour. Okay, and here's what I told you what you should do in a patient with new focal deficit during the alteplase infusion. Okay, glucose. On these patients, you can keep glucose usually on values from 140 to 180. This is true for most of the patients in critical status. Okay, remember, we don't want to lower glucose to normal values. Okay, these are patients that are under a stress status, so we just leave patients with those glucose is fine. Sorry. And before giving anything by mouth to these patients, remember that we have to do a swallow test with 30 milliliters of water to see if the patient is able to swallow correctly. Okay, remember that these patients had a stroke and maybe they have deficit with the swallowing. And if we start to give oral aliments to the oral food to these patients, we can have a unfavorable reaction. Okay, and so this is also important. If alteplase was administered for patients that were candidates, you should avoid indwelling catheter, nasogastric tubes, and intraarterial catheters for the following 4 hours, and not give anticoagulants or antiplatelet therapies for up to 24 hours. And urinary catheters are only to be used if they are absolutely needed. Okay, so that's pretty much it, how to approach a patient with an ischemic stroke. Thank you.